Guys, in deference to time, while Donna's pulling that together, I'm going to go ahead and call the meeting to order if we could. I'm Rob Sprang from UK. I'm the chair of the telehealth board. Do you want to have all the board members in attendance introduce themselves? Okay, if we could. No, I'm sorry.
Just go on and
okay, well, I tell you what, let's just go around we'll go around the network first and let you guys introduce yourselves, and then we'll have the UK room introduce themselves. U of L, would you guys like to start, please?
I'm Tim Nickel, the telehealth director at the University of Louisville.
Bob Esterhay, University of Louisville, School of Public Health and Information Sciences.
I'm Robert Caudell. I'm a psychiatrist with the University of Louisville and director of our telemedicine programs within the department.
Great, thank you guys. And St. Clair Regional Medical Center?
Good morning, everyone. I'm Mary Horsley, and I'm the telehealth director here at St. Clair and Moorhead.
Thanks, Mary. And Baptist Madisonville?
Steve Fricker, telehealth director at Baptist Madisonville.
Thanks, Steve. And do we have anybody on the network that we have not done roll call with? It looks like we have 2 people connected by phone. So if you have to be on the phone, if you'd unmute your telephone and speak up. All right, we'll move from there. We'll go around the table first and then the outside. Rodney, if you start, please.
I'm Rodney Murphy, Executive Director of the Office of Administrative and Technology Services for the Cabinet for Health and Family Services.
Jim Bardenhart, Commonwealth Office of Technology.
Jamie Burton, CEO of the Adulta Group.
And Russ Bissett, member at large, recently retired from the University of Louisville. Bill Hacker, former Commissioner of Public Health, now retired and member at large.
Okay, thanks, Dr. Hacker. We can start over here, please.
I'm Robert Slayton. I do some consulting in healthcare. I'm just interested in what y'all are up to.
Okay.
David Ball, Kentucky Primary Care Association.
Good morning, I'm Vaughn Payne. I'm Medical Director for Humana Care Source.
I'm Howard Schatz, Medical Director for WellCare Health Plans.
Marie Cole, Copenhagen.
Kelly Rodman, Humana.
Steve Hoagland, I'm Chief Medical Officer for Passport Health Plan.
Fred Saline, Coventry Cares.
Jamie Couch, the Board of Hospital Director of Clinic Operations.
John Langfeld, Department of Medicaid.
Carla Crane, Office of Health Policy.
Barry Elliott, Trinity Telemedicine.
Gary Farmer, Trinity Telemedicine.
John James, Hospital Trinity.
Ted Kroll, Medical Director, Department of Corrections.
Jeff Trzaskowski, I'm with Correct Care Solutions.
Jacqueline Elite, Post NPPH.
Greg Bennett, Correct Care Solutions.
Paula Lois Stentman with the Kentucky Health Information Exchange.
Great, thank you guys. Again, we have 2 people, I think, on the telephone. If you guys want to check in, if not, we'll move on. Okay, for board members, I hope you've had a chance to review the March meeting minutes. I don't really want to take time here if we haven't, but if I could have a motion, please, to approve or any changes.
Move to accept the minutes.
All right. We have a second. Before we take a vote, any discussion on the minutes? All right, the board members, all in favor of approving the minutes, please say aye.
Aye. Aye.
All opposed, say nay. All right, the March board minutes have been approved. Thank you, guys. We have 2 policy revisions, Donna, is that correct? Okay, we have 2 policy revisions that you guys should have listed, blue things on top, blue banner on top of the page. The first one, let's see. The first one is we added a form for contact information for telehealth technology, adding telehealth clinical encounters where H.323 standards-based video conference technology is not utilized or not eligible for Medicaid reimbursement. proprietary technologies that are not compatible with 323 standards are acceptable for Medicare and private insurance claims. It's compliance with the requirement in the administrative reg. So I think the standards-based technology has always been the mandate. I think what we said was Medicare and commercial insurance does not have that same mandate. Is that correct, Donna? Okay, so that's why we added that statement. We didn't want people to think that you cannot do telehealth if you don't use standards-based technology. And just, I don't want to go into much detail on this, but guys, when we first put this network together in 2000, we were told very specifically by the legislature, we do not want you to create islands of technology where people can't speak to one another. What we don't want is a small system in Western Kentucky, and then you uncover a patient in Paducah that needs to speak to a University of Louisville doctor, and we say, well, sorry, we can't do that because the little system you created will not talk to the larger state network. But I think it was really important. I think some people had the misconception that you couldn't do Medicare or private insurance telehealth, and there is no mandate other than Medicaid that says you have to use the standards. So I think this specific policy revision was simply to make that clear to people. Do we have any questions or comments or thoughts about that? Anybody on the network? Okay, guys, if that's the case, then I need a motion to accept KTHN 001, the updated membership policy.
So moved.
Okay, could I have a second?
Second.
All right. Any further discussion before we vote? Okay, all in favor of accepting the KTHN 001 revised membership policy, please affirm by saying aye.
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 Any opposed, say nay. All right, the motion is passed. Thank you guys very much. The second change that we made, which is in KTHN 006, about Medicare coverage reimbursement for telehealth originating site facility fee and telehealth professional fee. Again, under Medicaid rules, unlike private insurance and Medicare, we will not be paid at this time for the site where the patient is located to present the patient. Medicare rules began in 2001 allowing a facility fee. So the facility that presents the patient would make what is roughly a $25 facility fee in addition to the professional fee. That is not eligible at this time with Medicaid. And again, the language in our policy didn't state that it's okay with Medicare and private insurance. So we changed the language in order to make that clear. It's only as it relates to Medicaid. Does anybody have any questions about that? Okay. If I could please have a motion to accept KTHN 006 policy change.
I move. Second.
Second. All right. Any discussion before we have the vote? Okay, guys. All in favor of the language change in KTHN 006 policy, please affirm by saying aye.
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 All opposed, say nay. Great. Thank you, guys, for the vote. Okay. Let's move on to membership requests. It looks like we have a bunch of membership requests today. Between Norton, Kentucky 1, Methodist Hospital, Manchester, Primary Plus, Methodist Hospital, Union County and Trigg County Hospital. I think that is it. If we could, we'll begin with Norton Hospital. They're asking for the following sites: Harrison County Hospital, which is actually in Indiana, Carroll County Hospital in Carrollton, Kentucky, Twin Lakes Regional in Litchfield. I think the real question that we had here, we struggled with this for a bit, was that, again, membership in KTHN is only relevant as it relates to Medicaid. Medicare and commercial insurance does not mandate this. So only Medicaid, it's only important with Medicaid. And I think our question, and I think we have answered this among ourselves, was that if the healthcare facility in Indiana only has patients, there are no providers in Indiana that are going to see a Kentucky patient, we have no relevant, or we have no jurisdiction to have to add the Norton or the facility in Indiana to KTHN. We're glad to do it. We don't mind doing it. But as long as there isn't a physician in Indiana seeing patients in Kentucky, then the Indiana facility, I think we can go ahead and add them to the network. It just doesn't necessarily have any relevance to us. So, any comment or questions about adding the 3 hospitals that Norton has asked to be added to the network?
Have we tested their technology?
Let's see. Have we tested all of them?
Yes, I tested them.
Oh, okay. Thank you, Tim.
Even the one in Indiana.
Tim, did you connect to Indiana?
Indiana, I didn't, because it was decided for the very reason that they weren't going to be seeing Kentucky Medicaid patients.
Right. Okay. You know, and I think just for their benefit, since they asked for it, why don't we approve the 2 Kentucky sites? We have been tested. Why don't we give provisional approval to the Indiana site subject to our testing with them? That way we won't have to reconvene the board for that, and it would save trouble, but, you know.
That's what we've done in the past.
Yeah, that's what we've done in the past. So if that's okay with you guys, any thoughts, comments, questions about that?
And then if they do see a Medicaid patient from Kentucky, they'll be prepared
right.
to provide the service.
Exactly.
Right. Sure shoot, we don't. The first patient they see is going to be a Kentucky Medicaid patient.
I mean, I guess it's possible that Norton could have an outreach clinic that they would send providers up there, and maybe it just happens to be to see one of their clinicians who's normally in Louisville would happen to go there. So.
And sometimes that was just for the general knowledge of everyone. Sometimes that will happen because the specialists will be seeing patients. They'll have a schedule for seeing patients in court in Indiana. If the patient may need some urgent care and they can't schedule them in Louisville for an appointment within, say, the next month or 2, but a patient that needs to be seen and there's an open slot on the Corridon schedule, there may be a Kentucky patient that will drive to Corridon, and it's just right up the road. So things like that can happen with scheduling issues.
Okay, guys. So what we need is if I could have a motion to accept the 3 hospitals that have been requested by Norton, with the caveat that the one Indiana hospital is provisional until we actually do technical testing with them.
I move. Second.
All right. Thank you, guys. Before we vote, any comments? All right. All in favor of the approval of the 3 sites requested by Norton, subject to the Indiana site being having technical testing, please respond by saying aye.
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 All opposed, say nay. Great. Thank you, guys. Donna, you'll let them know. Okay, wonderful. Thank you. Hey, guys, we have a whole series of requests that have come from Kentucky One, St. Joseph Healthcare. 12, 14, 15 sites available. Don't need to go through these at all. We've tested with every one of these, haven't we? Right. Yes, Tim, thank you very much for your work on that.
Right. We did test. There was one that in our original list, I don't know, did you all pass out a list there in Frankfurt? I didn't see one attached to the.
No, we didn't.
Probably not.
Okay. There's a couple of changes from what we were originally given from them, but like one was added and one was deleted. But yeah, every facility's been tested.
Okay, so,
The original list is this,
okay,
and then they update.
And
okay.
Deborah Burton is going to send us an updated list.
Yeah, I've got it.
We have that list. Donna has that
Okay.
list. But the board does not have that. Okay. Board, are you guys willing to give us the faith to accept the sites that have been
You
requested
can
by?
name them all.
Okay, is that it, or is this, okay, okay, I'll go through these really quick. I'll just go through the cities. The facility in Owensville, Kentucky One Primary Care, Lake County, same in Camden, Virtual Care Community Health Service, Parker House, Lexington, Physicians Group in Lexington, Urology, a Pulmonology Group, a Neurology Group, Cardiology Women's Health Group, a Cardiology Group also in Lexington, Diabetes and Nutritional Counseling in Lexington, Sleep Wellness Center in Lexington, the Sleep Wellness Center in Berea, the Transplant Center in Lexington, Our Lady of Peace in Louisville, Saints Mary and Elizabeth in Louisville, and finally Kentucky One Health, St. Joseph, London. Those sites have been requested and all been tested. So any questions on those? I'd like to have a motion if we could to...
Quick question.
Yeah.
So if a sleep site, will they go connect to the St. Joe Bridge, then connect to the telehealth network, or do they in each one, and is there a capacity issue that we will eventually run out of?
They can connect through the bridge, or they can connect directly to any, not only of the St. Joe's, but literally anybody in the state. So, no, I don't think we don't have it. Now, we have a capacity problem if we do an educational program and everybody in the state wants to participate, but we've never run into that. And actually, if we leverage the state of Kentucky's bridge, we actually have over 400 ports of capacity, which is more than the aggregate of all of our, we probably are up to 250 telehealth sites in the state. So we have about 250 approved sites, and literally between Louisville, UK, and the state, we're probably up to 600 ports of capacity. So we can handle everybody at once if we wanted to.
Right.
But the vast majority of these programs, these clinical programs will be a direct connection between one facility and the provider. Okay. Could we have a motion, please, to accept all of the St. Joseph Kentucky One sites for membership?
Move to accept.
All right. Do you have a second?
Second.
Thank you. Any discussion before the vote? All right, guys. Please respond by saying aye to accept all of the Kentucky One St. Joseph healthcare sites through Kentucky Health Network.
Aye.
Aye.
All opposed say nay. Great. Thank you guys very much. Next request comes from Methodist Hospital in Henderson. They requested membership to the network. Kenny, do we have you online?
Yes, sir.
Oh, very good, Kenny. Thank you. I think that, Kenny, as I understand, we're going to move for provisional approval contingent to testing with new equipment that you either have or are going to get. Is that correct?
That is exactly right, Rob.
Okay. And I can tell you, I've been to Methodist, and they have Polycom equipment. It is dedicated for educational programs in the boardroom, and we have made that connection. So I have every confidence that we won't have any problems with that, but they will still need provisional approval into the network. Could I have a motion to approve Methodist Hospital in Henderson to the network?
Move. Second.
Thank you. Thank you. Any discussion before the vote? All right. All in favor of approving Methodist Hospital to KTHN Network?
Provisional.
Subject to provisional testing for the technology, please say aye.
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 And all opposed say nay. Great. Thank you, guys. And we have representatives from Manchester Memorial today. They're requesting membership for the hospital and the Willowbrook Women's Clinic. Thoughts, comments, anything you want to say to the board?
We do not have the equipment yet for the Willowbrook Women's Clinic. We have the Polycom Group 500 Eagle Eye acoustic camera, the equipment that should be in it and ready to go by August 2nd. So
Okay.
We've not tested it, of course.
Okay. All right. Great. So yeah, again, this will be a provisional membership to the network, and I can tell you, Manchester has video conferencing equipment through corporate, and again, it's dedicated to education, but we connected it to the network, so we have no doubt that we'll be able to make that work. So if we could have a a motion to join, at Manchester Memorial join the network.
Provisional.
Provisional, please. Thank you.
Second.
All right. And all in favor of provisional approval for Manchester Memorial Hospital to KTHN Network, please say aye.
Aye.
All opposed, say nay.
Quick question.
Yes, sir.
Where's Willowbrook?
Willowbrook is in Manchester.
Okay, so that's there in town.
Yes.
Okay.
It's on the campus.
It is within Rockville
Okay.
Hospital.
Yeah.
So, yeah.
I know where you're at.
Okay. All right. Again, thank you, everybody. Manchester is approved. Let's see. I don't think Jerry is connected, unless Jerry's connected by phone. Jerry Ugrin? Three of you guys hiding out on the phone. I don't know who it is. So, all right. Well, we have had a request from Primary Plus for membership of 2 additional sites. Primary Plus was one of the early members of KTHN when we began the network. They are asking for membership of Maysville OB-GYN Family Health Care and South Shore Family Health Center. As I understand, the equipment is not in place at this time. I don't believe it is, so I think we will be asking for provisional approval of Primary Plus, subject to technology testing.
Yeah.
Okay, provisional approval. Okay, could I have a motion, please?
Move for approval.
Can we have a second? Thank you. And all in favor of approving Primary Plus for provisional membership, subject to technology testing, please say aye.
Aye.
All opposed, say nay. All right, thanks again, guys. We have had a request from Methodist Hospital, Union County, and Trigg County Hospitals. This request came in due to a rural utility service grant that was funded out, I think we're calling it loosely the Western Kentucky Project. I think we have several sites connected. Methodist Hospital and Trigg County Hospital both have the technology. Have we tested? Okay. They have
Not
the
unless Amy has tested just for the last week.
Steve, do you know if Amy has tested with them?
I'm fairly certain Trigg County has. I'm not sure about Union County. Let me see if I can find out real quick.
Okay, great. Kenny, do you have any input on that?
Indirectly, sir. To my knowledge, it has not been tested, sir.
Okay. All right. And if we tested, great, but if we could, let's have a motion to accept Methodist and Trigg County subject to technology testing.
Motion.
Thank you. Thank you. All in favor of approving Methodist and Trigg contingent upon technology testing, please say aye.
Aye.
All opposed, say nay. All right, thank you, guys. Okay, that is the, I think those are the requests that we've had so far. Now, we also, has Communicare made the request? Is that where
We've
we
got
stand
Trinity
right now?
Video folks with us
Right.
today, and they wanted to ask about a cloud-based gateway.
Right. So, you guys want to explain it? You want me to? I don't mind doing it, but I'm glad to let you guys. You took the time to come here. You want to explain it?
And thanks for the invite, Rob. So we've been working with Communicare in Newtown. They're looking to do and Barry can probably speak forward to their
I
clinical
know your
use.
voice is low. You may. Just
I'm sorry.
for those folks.
I
know.
and I'm just getting over the same
Yeah.
cold that Rob has, so a little scratchy. We're a Polycom Cisco provider, but also we sell video with a wide that platform. It's a software-based video communications platform. And that's what we've been talking to Communicare about, because it fit their particular use case quite well. And it's not H.323 based. It's a more modern, scalable platform. But it is based on a more recent standard, I guess you should say. So video does sell a gateway that lets you cross over into 323 very cleanly, and we've tested that. We've done that. We use that on a regular basis. We have a number of customers that have that in place, but it's not a cheap piece of equipment. I mean, this is a fairly small footprint, small need type. Bring your own device type platform where their patients are going to be on their iPads or different types of devices. And so, so we were trying to value engineer, as we say, in the integrator side of the business. We were trying to value engineer a solution for them. And one of the solutions is a cloud-based bridging type capability that is essentially very inexpensive and would allow them, in the rare case they may need to connect to UK or something like that, the two endpoints essentially join in the cloud. It's still HIPAA compliant, secure, and all that kind of stuff. But it's not in a situation where I'd normally call it traditional straight bridge to a 323 network. And I asked Rob about it, and he went, that's a little different. We might want to talk about it. So the capability is still there, right? And we're just trying to give our customer the lowest price option they can get to, because their budget's very limited. And this has come up now with 2 or 3 different customers in that niche. We've been talking to the communicators from all over the state, and they're all kind of have that same kind of very small budget, same unique kind of specific requirement. Makes this a nice fit, but we don't want to do anything that would mess up the Medicaid reimbursement.
No, and I appreciate that. And I got to tell you guys, my only concern on this, and technologically this doesn't make a whole lot of sense, they're going to have to go to, and who does offer? Is it actually video offers?
Yeah.
Okay. Yeah. So the company that makes the equipment and the software for these companies, which resides at corporate headquarters or where literally it can be anywhere in the world on the net, they will tell you, you channel your proprietary communication, or at least proprietary to us, through our server, and we can connect you to literally anybody in the world. We have approved this before, but a hardware solution that actually sits at the customer's location. Signature Healthcare uses video, and Bluegrass CommCare has an installation of it. And we have approved that, but the device that makes that gateway that allows the conversion to take place sits on the patient's premise. My only concern, and you guys know this way better than I do, are there security risks when we go to somebody else out there managing this for us? Where, again, I don't know a technician. I just don't know.
Right. Well, I guess the answer is anytime you're on the public network, there's a certain security risk. But it is all encrypted, and it is encrypted from endpoint to endpoint. So it's all S128 encryption. Since I know how that device works, because we have them and I put them in, I know that device stores nothing, and it's strictly data in transit. It's essentially doing a bridging type service. So I know that there's nothing on that device other than the fact that these 2 locations connected.
It's an elegant solution. It really works well. I can just tell you from my perspective and what I know about it, I would be comfortable with this. I can also tell you that everybody in the network is supposed to, if they're not, then they're violating our regs, should be doing a complete consent of every patient. And in the form that most of us use, we're very upfront. I think Target and Neiman's proved to us nothing's safe. Really, if you want something, you're going to get it out on the net. But we do and I don't care whether you call it HIPAA compliant or people can get things if they really want. So I think we have to be completely transparent with patients. I think we all do that in our consent forms, where we say we're going to do everything we can to protect you, but you need to know this is happening electronically. And if you don't feel comfortable with it, don't do it. And you can request at any time in the encounter to ask to see the provider in person. Now, you'll run into all the problems of having to wait and to travel, but that is your outlet. So we do that for every patient. So from a technological perspective, I'm comfortable with this, but I want to make sure that the board and everybody at the table has a chance to talk about it. So any discussion?
So when you're talking endpoint to endpoint, you're also talking, if I want to talk to my therapist on my personal cell phone, you're calling me an endpoint.
Right.
So it's that bridge that's making that
But
secure.
they wouldn't need it for their internal consults.
Right.
This would be only if they need to connect to UK or U of L or something like that on a 323 environment.
Okay, so they're not actually hooking up with a client on a cell phone or an iPad or.
Oh, yeah.
It
would
could
be,
be.
but
Yeah.
it would be within their own equipment at
Right.
that point.
Right. Okay.
Jane, the equipment that you have, the
Yeah.
traditional Polycom or
Right.
video conference systems, we know that works with everything. Video, it's not like it's something somebody just made up. I mean,
Right.
it is a standard. It's just not the same standard that the state is built on. And so among Communicare, they're great. iPads, the iPad, computer, whatever, that'll work fine. But then somebody says, well, I need you to see one of the pediatric or adolescent psychiatrists at U of L. Now you've got to go outside Communicare. You can't do that unless you have this service available to you. And in their case, instead of spending $10,000 roughly,
Yeah, roughly. Yeah.
$10,000 for something that they probably will rarely, if ever, need, there is a service provider. The company says, well, you know what, you can run it through hours and maybe pay.
It's free.
Really?
Yeah.
Okay.
It's free. It's meant for small businesses
Right.
that are specifically in this type of situation.
If they started using it every day and began to chew up those resources, they probably would come back and go, okay, that's not what we intended by free. But yeah, so they could do that. It's a very elegant solution.
I think it's a good idea.
Any other comments, thoughts?
You didn't raise any concerns till you said free. How can they offer it free?
For this, to close the deal, they're essentially, they're offering it to their smaller, small businesses to be able to, for them to kind of get over this hurdle where they have this particular need, but yet don't really want to spend, $10,000 for to check a box kind of thing.
And I'm not trying to derail this, but we have a new law in Kentucky called House Bill 5 related to breach notification, if we would have any breaches and so forth. What type of situation would we have if we had a breach as a result of the hands of that service provider of patient data? And what kind of cooperation can we make sure we have as a result of that? Again, I know this sounds terrible.
No.
Good
it's an issue we've got to deal with.
It's a fair question, and also when you get into the world of telehealth and especially interactive video conferencing, which is what you're talking about, HIPAA doesn't really apply to that. It's electronic patient information. So when you get into video, it's kind of it's kind of like cell phones. HIPAA doesn't apply to a cell phone call, and yet more patient information is passed back and forth on cell phones, which are probably as easy to capture as anything imaginable.
Doctor, correct me if I'm wrong, but House Bill 5 is not relegated to just HIPAA information. It's personally identifiable information, so it's a lot broader than what we're normally dealing with.
Wonder what we could. I wonder if we could talk to video about that. That if we're going to channel, what could we expect? But Ronnie, what are your thoughts? What do you think we could do that maybe would make people comfortable with that?
I think we need to probably look at whatever kind of business associate agreement we could create with those guys or whatever to set expectations, but also make sure they understand what the requirements are in the new law. Again, I just think we need to have some further discussion on that and make sure they're aware of what we're faced with.
My guess is that video probably has a templated BAA.
I don't know. I can't imagine not. I mean, they're doing about as much in healthcare as anybody.
Exactly.
Yeah. Yeah, let's find a way to make it happen, because it sounds like it'd be beneficial for the
Let's-
program.
Okay.
But I think we ought to do a little more research before we move.
Are we in a position, just because, I don't know, what is CommuniCare's timeline? You know, have they given you a?
They're wanting to act pretty soon. I think their budget year is July 1.
Yeah, it is.
Okay. And they're probably a majority of Medicaid patients.
Yeah.
Okay. Because I don't want to delay this till the next board meeting, if we can do some kind of a provision. You think we could do a provisional, that way we could reach out to board members to approve?
Well, we did approve CommuniCare last in March,
Okay.
subject to provisional, subject to testing. and
But that's
testing.
yeah, but see, now they've come back and said, we're going to use this technology, which now needs approval.
Provisional approval.
I see what you're saying. So, I think we will need now we're not testing technical evaluation, we're testing the security and testing. Okay. So if you guys are comfortable.
Since I'm bringing up the problem.
Thank you.
Let me make a motion. I move that we approve this connection, provisional to testing, the technology as well as review and approval of the business arrangement.
Perfect.
With this provider.
Thank you.
All right.
So we have a second. Any discussion before the vote? All right. All in favor of Rodney's motion, please say aye. Aye. All opposed say nay. All right. Motion carries. Thank you, guys. That was very helpful. I wanted to, I'm sorry, your notes. Oh, okay. Did we send the Federation of State Medical Boards? Okay. Guys, the Federation of State Medical Boards, and really in conjunction with the AMA and the Federation, AMA, and CDC have had great concerns, and there's one company in particular called Teledoc that does call center provision of care on the telephone. And I think as I understand, early data shows that if you call this telephone, again, they have no data on patients whatsoever. If you call them on the telephone, and within about 5 minutes of describing, oh, it feels so good, and I have, running a fever, then you're going to get a Z-Pack or something called into the local Walgreens. And I think you get that, as I understand, about 99% of the time. So I think we all realize that we have an antibiotic overprescribing problem, and nobody knows that better than CDC and AMA, Federation, and so they have great concern about this. And so there are all modalities that people are doing telehealth, but there is a great concern about this. And there have been a couple of kind of high-profile issues that have come up recently. I think a primary care physician in Utah lost their credentials because they did just that. They prescribed antibiotics. They were licensed in the state, but they prescribed antibiotics on one of these telephone calls. They thought they were doing the right thing. The company, which has 3 million customers, I mean, they're out there. They have, they have a big legal team, and they told the doctors, yeah, this is fine, you're covered. And the doctor kind of took that for granted, and now she may lose her medical license. So there are concerns about these, especially telephone-only programs. And the Federation wrote a policy to address that specifically. If you guys don't have copies of it, we can be sure and send it to you. Frankly, the Federation adopting this doesn't mean anything. It doesn't matter. If state medical boards don't adopt it, it goes nowhere. So we don't know where this is going to go. We don't know if the Federation is going to promote this at the state level, but the Federation came out at a national level and did this. So I don't know if anybody's seen this or heard this or has any questions about it or thoughts. I just wanted to make you guys aware that that's one of those things that certainly we as a telehealth entity have to deal with. People are going to say, well, I just want to call on the phone and get a Z-Pack so I can send my kid to school. That's, the Federation says no, but again, until it is taken up at the state level, that doesn't matter. Any thoughts? Just thought I'd bring it to your attention.
Well,
Okay.
I will make a quick comment, Rob. I was on the board for 7 years, the state board in Lasseter. Lots of issues dealing with this out-of-state docs doing consultations in the state, and how do you set boundaries, and how do you establish quality of care? And it's just going to get worse. I mean, that's the bottom line of it all. What the national record, for you folks who don't know, state licensure is a state licensure issue. It's one of those things that there's not a national license in medicine. So each state determines its own standards of what you can do under what circumstances. And so this interstate clinical care gets complicated. And physicians have called each other across state lines for years. I've got this patient, what should I do? But it's there's a difference between commercial making money at it versus clinical care, really more higher standards of care. How you define what's a beauty and what's not beauty is equally difficult to do. So for those who are not living in the medical clinical world, it's very complicated. There's not a good answer.
And the Federation, I think, is very clear in their guidelines. People have been prescribing on the phone forever, since there was the telephone and there were prescriptions, but they were your patients. So, my doctor who knows me, and some doctors still won't do it, but if your doctor knows you, and I get a cold every spring and every fall, and they know it, and I call in, and that doctor may write a script. These are not my doctor. They do actually use the on-call language as a safe harbor. Well, we're the on-call doctor. We're 8 states away, and we never talk to your doctor except to sign the contract. But again, the telephone-based services, just Federation, and I think part of the problem the Federation faces is horses out of the barn. I mean, these companies are doing this, and the issue is that they said it reduces emergency room visits. I bet it does. I remember when my kids were little, and I really seriously thought about using this because as a consumer, not a clinician, I think every time my kid feels bad, they need an antibiotic. So give them an antibiotic, let me send them to school the next day. That's not how it works. And so the Federation kind of came out on this. I wanted you guys to be aware of this. And the one group that has come out and really concerned about this is Teladoc, because they are a 100% telephone-based call center for doctors.
Just to comment on Dr. Hankerstein, which I agree with, but there is an answer. I mean, you guys will have to determine someday how good, but a fully mature national health information exchange network would allow providers to see status of care and patient history and all those sorts of things that would provide better decision support information at that point of service or any other point of service. Will it overcome this dilemma? I don't know, but I mean, it underscores the importance of Polly's program and what we're trying to do there with electronic medical records.
Call Polly, get them up with
There you go.
She's always on call.
I think what you will see is that people begin to take this technology and use it in their practice. Now I realize no physician wants to take call in the evening or weekends, but as we move to the development of ACOs, actually there are provisions where you have to take call. I mean, you have to do that. And so I think what we will do is we will bring care back down to the local practice again. And so I have no doubt that this kind of technology will take off, whether it's web-based, whether it's phone-based, but I think it will be brought back into the practice. But again, the Federation just, they look at what this, specifically what this one company did.
Theoretically, it's practiced today in the emergency room, right? If I go to the emergency room, the doc that I see has probably never seen me before.
And has no medical record.
And has no medical record of me. So,
True.
I mean, I don't know how it differs from that. Interesting situation.
Yeah, but I get to look.
That's correct.
Yeah.
Since it's during my e-market.
Yes, sir.
Well, as I'm saying,
That's what he was just saying.
Reach out to you.
the American Medical Association at their annual meeting last week came out against interstate use of telemedicine for something very similar to this.
Really?
Or for whatever that means in terms of what the AMA says. That's
Did they qualify that? I mean, I know there have been suggestions. I mean, I know that legislators have been promoting this kind of national license and everything. But did they qualify cross-state at all?
I think it's a medical licensure.
Okay.
Well, and also face-to-face, with the exception of radiologists. It was a fairly engrossing dynamic in their adoption process, what they discussed.
Okay.
So that brings up a whole another can of worms, and we've got a lot of providers signing up to get their Medicaid number because the whole Medicaid system has changed and you have to have your own independent number. So I was just wondering if we could get those persons or those entities who are signing up for the new numbers, if we could get those and send a letter out and go, if you're going to do telehealth, because we know some of them will have to do telehealth because they're not going to hire psychiatrists, doctors, whatever, across the state, and they've probably never even heard of a telehealth board. They know they can have a TV camera, or they can do it on a computer, or they can not use video, but they might use, one of the other entities out there that are not compliant whatsoever. So is there any way we could get when somebody gets approved,
I mean, it's a very fair question, and in our weekly training center meetings, we talk about there is no check and balance. I mean, we approve people that come to us, but if they don't come to us, we don't approve and we don't know about them.
And then Medicaid doesn't know if they've been approved by the board in compliance with the.
Rodney's brought this up a
That's
couple
right.
times.
Well, again, I'm talking about futures, but we are in the process of trying to develop the business, or of documenting the business requirements for an online provider portal and enrollment system. And that's where that should be added, and that would be not so difficult to do. Not only to provide information about the requirements for the telehealth board, but also to identify that provider as a telemedicine provider. So I will discuss this.
Yeah, can we throw it on the paper application? Because I know we're filling out a ton of them.
Well, that's the purpose of this.
I know.
Again, I never know. Every time I approach something to get rid of paper, it just creates more paper. So,
I know.
I've quit saying that in my career.
All right. Any other comments? If you guys want to know more about this, we can channel some information to you. The Center for Telehealth and eHealth Law in Washington and the American Telemedicine Association keep up with us pretty closely.
I do have one suggestion. Send a letter to the chairman of the board of the Kentucky Medical Licensure Board, asking are they taking any action on the federal.
Okay.
And just so we'll know what actions, if any, the state's going to take.
Right idea. Yeah. Yeah.
It's a concern of ours, the board.
Okay.
Never hurts to say hello.
So will this come from the board? Do you want me to send it as chair representing the board?
Okay, I'll make that motion. I make the motion that Rob send a letter to the head of the chairman of the board. Second that.
Okay.
Just simply asking what we're concerned, we have this dialogue, and what are the actions, if any, they're going to take.
Okay. Do we need to?
Anybody opposed?
Anybody opposed?
No, second, Rob.
No, okay, great. Thank you, guys. Again, the world is changing so quickly. There are some very, very smart entrepreneurs out there that are doing this. So,
I'm going to say one more thing.
Yeah.
You might include in the letter, if anyone would like, someone from the board would like to meet with the telehealth board at some point in the future, discuss their dialogue and to see if there's any, can we inform their dialogue better through the competency and the technology and dialogues we have, if that's of interest. Happy to invite you to that.
Okay. Good, thank you. All right. utilizing telehealth for Kentucky Department of Correction. Oh, I got to this. That's great.
It's been a long time, hasn't it?
It has. And I'm sure a lot of people don't know kind of progress and processes taking place. But you guys, I'd just like to turn it over to y'all and and talk about what's happened and what will happen.
Happy to do it. Thank you very much. My name is Jeff Trzaskowski. I'm with Correct Care Solutions. With me today is Greg Bennett, who's our IT project manager, and also here is Dr. Kroll from the Department of Corrections, who you may or may not know. But thank you very much to Rob and to the entire board for allowing us to be here today. We wanted to come in and just let you know who we are, what we're doing here, how we use telehealth now, how we're looking to expand the role of telehealth across corrections in the state, and then any technical questions you can direct to Greg. He can at least tell you what equipment we have and how we're utilizing it. So if I can take a few minutes up front to just tell you that, give you the introduction of CCS and what we're doing here, I appreciate it. So we are a healthcare company. We just happen to practice our healthcare in jails and prisons all across the country. We do that in 32 states, including Kentucky. We're headquartered in Nashville, Tennessee, but we have opened an office here in Kentucky in Louisville, at the east end of Louisville, near the Ford plant at Westport Road and Chamberlain Lane, if you know the area. We began speaking with Rob about 2 years ago, I think, when we knew that this contract was coming up for bid, and we finally began working with the state on March 1st of this year. So what we do is we provide really primary care services on site for 20,000 patients every day across 12 institutions. So we bring physicians on site, we bring nurses, x-ray lab, there's pharmacy, and we bring specialty care providers on site as well, either in person or via telehealth. Our goal is obviously to provide appropriate quality care for these patients at the best possible price, because the bill's paid by all of us. Now I live here now, so I can say us, Kentucky taxpayers. So that is our goal. And so part of that is minimizing runs out to local hospitals, because that requires security to go with them and costs escalate and all of that. So the more we can do on site, the better. So currently on site, we're providing psychiatric services via telehealth. We have, I think, 7 psychiatrists across the state that are employed by us. And we have telemedicine equipment, and those 7 can take care currently of the 12 institutions across the state. So some are in person at some, but other is telehealth. We actually are looking for 2 psychiatric nurse practitioners, or even 40 hours for 1 psychiatrist to help us as well. So if you have any interest or know anybody in your network that may want to help us with some psychiatric telehealth, please let me know. We're also working with the University of Louisville Division of Infectious Diseases. They are providing infectious disease consultations for our patients via telehealth as well. So that has been going on since March. Obviously, we're expanding that as well. And I think over time we'll see that grow to include GI and some hepatitis C and some other modalities as well. Across the country, we've been using telehealth since 2005. We do cardiology, neurology, a number of things across the country. And as we get our feet on the ground here, we're going to be working with the DOC to expand things where appropriate as well. So maybe bring some cardiology telehealth on site and do a number of other things where it's appropriate. And that's kind of who we are and what we do. Does that make sense to everybody? Anybody have experience working with us at all, with the DOC or any of your people? Other than the U of L folks? Okay.
I just got back from my visit to Eddyville Friday.
Okay.
It was absolutely a wonderful trip. I mean, if you could say a trip like that is wonderful.
I understand.
But spent the day with the warden and the commissioner.
Okay.
And, I mean, if anyone ever gets a chance to do it, they should do that. I'd really encourage it.
And we for the provision of telehealth services, we can contract directly with the providers. We also have an arrangement with Humana that any of our patients who do need to leave a Kentucky DOC institution for care, if they have to go off-site for a consult at a hospital, if somebody falls out of a bunk, for example, breaks their arm, and it's a weekend, we don't have a provider, we will send them to the hospital. And those patients actually leave with a Humana card. So they are Humana patients that gets billed from the hospital directly to Humana. And so for telehealth services, we can coordinate the billing of that through Humana when it's appropriate as well. So we've got a number of different options that we can do to manage that on the fiscal side as well. Any questions? Yeah.
So do you have an electronic health record?
The state maintains an electronic health record, and they're in the process of possibly upgrading that. I don't know if you want to speak to that.
The contract isn't signed yet, but a new electronic health vendor has been chosen.
I have heard that rumor. Okay, we should talk, because we'll want to connect into the Kentucky Health Information Exchange. That's wonderful. That is just wonderful.
good. So we're happy to be here. We're glad to be doing this. And again, we want to do more telemedicine. We want to do more with this group. We want to make sure we're not doing things in a vacuum or doing things that are in conflict with the goals of this group. So we're glad to be here. We want to continue to participate and be involved so we understand what's happening. Make sure the care of those 20,000 patients is appropriate from your point of view as well. So I'll let Greg speak quickly to our technical capabilities and how we're managing things on that side.
Well, the only thing, as we're finding out in Kentucky, they have a very expansive telehealth network here, which we work in other states where they're pretty much non-existent as far as telehealth. So when we come into a contract or something, we have to find an easy solution. And we use, throughout our contracts, we use a lot of Microsoft Link for it. It's an easy way to, so us connecting to your network to provide other resources, I mean, we're interested in that too, but as far as telehealth wise, you're way beyond what we expected and what we can find. We'd like to expand that just inside the prison system, just with inside, so we're not, we're eliminating inmate movement, patient movement, because anytime, even moving across the yard is complicated in our process. So, but I think our goal is to first learn what you're doing, what your capabilities are, then move on to how we can integrate that into the rest of our resources that we have outside of the state of Kentucky if need be. But your discussion's been interesting too. So.
Well, and I think it's important to know this program doesn't begin and end at UK U of L. I mean, it's easy to look at the academic medical centers and you got a lot of the medical specialties there. But this network includes hospitals all over the state, clinics all over the state. So, our goal, the telehealth network, always has been keep patients as close to them as possible. And so if there's a community-based specialist that you can leverage, we want you to do that. I mean, again, don't want it all to come back to the large centers. If we can keep, because then if you've got to see that provider, you just go down the road instead of halfway across the state. So I think I would offer the state network to you guys is you have a pretty robust service that you have access to. We'll deal with this however you want. My guess would be we would just kind of wait for you guys to say, we need this.
Sure.
Because just because we don't do a service doesn't mean we can't do a service. So, the most important things that we have on this network are the things we don't do yet and will do in the future. So I think we'll just, you have this accessible to you, and between the 4 training center directors, we will be there to do whatever we can to connect you to the right resources.
Thank you.
So Jeff, thank you for that. It's been great working with you even up to this.
Very glad to be here.
Tim,
this is yes. Since we are currently providing our services here, I would like to work with you in moving forward a little bit, because we do have some physicians that have some positive input on how to improve those services going forward. So if you don't mind, sometime after this meeting, maybe we can get together and have a conference and have a meeting to address some issues that we have that might improve services.
That'd be great. We'd love to do that live. You're in Louisville, I'm assuming, correct?
Right. And since three of we're providing currently services to 10 different telehealth sites that we've already connected up with, 10 different facilities across the state. So we're providing our infectious disease program from one end of the state to the other. But the 3 major medical facilities, from what I understand, are just right outside Louisville. So that, I think one reason U of L was chosen to provide some of these services is because they'll base those patients that have the most medical need in those facilities right outside our city limits. So,
true.
But thank you very much.
All right, Tim. I'll give you a call.
All right. Thank you.
Thank you.
Yeah, I just picked up on the UK U of L has.
Yeah,
I missed that. I'm not sure what. Okay, so any comments, thoughts about working with the state prison system and correct care solutions?
CCS, yeah, there was another
CCS.
correct care before.
Yeah.
So it's just easier to say CCS.
Well, and every company that does this is based out of Tennessee, I think.
There's
So
a lot
there's
of it.
a lot of them. So, all right. Well, good. Again, thank you guys for coming, and I guess we'll just be responsive. However you want to do this, bring the training center groups together, whatever you want.
Thanks, Rob.
Great. Okay, guys. I don't believe I've met Jeffrey Sutherland once, and I don't believe he's here. Okay. Jeffrey was going to come from Anthem to talk about behavioral health issues, but we will table that, pick it up at another time. We have had, and again, thanks to Dr. Langfeld, we've had some communications with the Medicaid managed care organizations, and again, I think again, kind of like with corrections, we'll be responsive to whatever you guys would like to do, but we had invited you guys here today mostly to see what we're doing, but I didn't know if you guys wanted to talk for a few minutes and maybe thoughts that you may have on what could we, help me help you. What could we do to help you guys? So certainly you've got the network all over the state, and I know we have done things with insurance companies before. I know we've had educational programs, whether it's for providers or staff people. So you guys, I don't know, we can start with Passport and then kind of just let the groups talk a little bit about what we can do to help out.
Love starting off. It's a lot of fun. We were joking. My intention was to just sit back and since it wasn't on the agenda. It's so different for my colleagues. Know I'm prone to speak up and start meetings. I'm Steve Hoagland. I'm the Chief Medical Officer for Passport, as I said earlier. And I think as we have moved from a health management organization for primarily for the 16 counties around Jefferson County, we've gotten a crash course in understanding about some of the challenges that Medicaid recipients and the Commonwealth faces around the state. And previous to me joining Passport, I was on faculty at U of L, and all my professional career has been in Louisville. I grew up in the west, kind of central southwestern part of the state. Had an identity crisis. We don't know whether to say we're in western Kentucky or south central Kentucky, but I had some familiarity at that point as being kind of more of a consumer, but not really on the provider side. I maintained some relationships there, but we do see that there's quite a bit of difference. But even when you look at the more rural, more urban setting, there's still pockets where there are gaps in care. And as technology has grown and people's willingness to embrace how technology can help meet some of the needs in healthcare, I think we have to remain engaged, understand where some of the challenges are, and how we can align a system to fill those gaps. And some of the conversations earlier today around facility use, for example, it's a conversation that we have with some providers who are wanting to participate. We have some flexibility that as a contractor with the state, we have some flexibility. There can be some sometimes unforeseen consequences whenever we exercise some of that flexibility. We have to have a conversation with our boss about how we can try to mitigate some of those with the understanding that we all want to put out the best product we possibly can to have an impact on members and at the end of the day, a positive impact on the health of the Commonwealth. Such a large, as you all know, such a large percentage of our citizens are Medicaid recipients. And so if we are able to improve the health of Medicaid recipients by 10%, 15%, it's going to have a pretty dramatic impact for the rest of the state. So it's something we're really interested in. But we have to continue to work through this and have conversations both within our groups then also outside with all of you to see how we can make the biggest impact. And one of the things that, something that I picked up on a little earlier, and it's probably because just I'm not aware and a little naivete, but you know, our provider file that we received from the state has telehealth provider type that is identified on there, and we actually report out who within our network is identified as a telehealth provider. And so understanding how that gets knitted together a little bit closer, you know, I think we can probably work together in helping broadcast who's eligible to provide the service, and then also how can we recruit more people to actually provide that service, and at the end of the day, close the gap where there are some. And we know that there are a lot, especially in the specialist areas.
Who wants to go next? Let any of you.
Rob, Fred Slynn, I'm the CMO at Coventry Care. I think you said a lot and said it well, Steve, like you usually do. The thing I would add is, you know, as managed care has changed delivery of care in the state over the last couple of years, I think we all have experienced maelstrom, maybe an appropriate term at the beginning, but now that it seems to have settled down a bit, we can really focus on what's important, and that is improving the health of individuals in the state, in particular the Medicaid population. And as Steve points out, and I said to John earlier today, that's our responsibility, is to make sure that the Medicaid population is getting appropriate, good health care. Not just that, but now I think we really can focus on improving their health care. And this is a mechanism which allows us to do that. And as you might also say, it checks off a bunch of boxes in terms of it's the opportunity to provide specialty care where it might otherwise not be available, and the project that we're supporting, that you're looking for now for funding, with the ability to diminish transfers in the emergency room and take care of some of the issues that we're dealing with the state. Collective problem in terms of overutilization of the emergency department. So.
And in doing that, we uncovered 161 helicopter trips in 1 year that the patient was discharged directly from ED. So at $18,000 per flight on average, it's a lot of money.
Well, I think a little bit of perspective.
You know it.
Yeah.
I'm an ER doc by trade, so I know that with us utilizing services outside the ER, you can definitely add value to what you're bringing. So we've been looking into it. I've been exploring it, and I think it's a very valuable resource that we have, so we can help our patients and our members get the right care at the right place. And you know, it's something that we definitely want to look forward to working with on.
Great. No, thank you guys. Thank you for coming.
I'm Vaughn Payne of the, we have an initiative with a care source in Ohio, something called Hotspot, I believe. That's an initial initiative looking into using this.
The health spot.
Health spot.
The kiosk. Yes.
The kiosk, right, exactly. From a personal perspective, I've just spent a few years in eastern Kentucky in a rural area, and can kind of see some potential, a lot of potential here. As a cardiologist, I see some high-level capabilities, I think, in terms of what we can do, what can be done in a synergistic fashion. I can see, for example, sending echo images across, which I think would be pretty cool. So yeah, so obviously we're just like all the other MCLs are interested in partnering.
Great. Any questions, comments, thoughts regarding our partnership with the MCOs?
The only thing I would say, Rob, is we have, from our workforce study, among a number of other things, we know we have gaps across the state at all levels. And as we look at our population holistically, and that includes many things, include transition from corrections, oral health, behavioral health, significant disconnect historically. How do we create linkages and the flow of communication between all providers so that we truly have an integrated system that we can deliver care, whether it's electronically on TV versus physically. And I think it is our opportunity to work hard to do
I know Tim's up there and probably can tell the story better than I do, but the go-to story of why we do that. And I do this especially as we talk to Medicare, because often people will look at how much money did we spend on reimbursing telehealth encounters. And you look at that at the end of the year. And in the Medicare world, when we first got Medicare approval back in 2001, the Congressional Budget Office said we project $150 million spending on telehealth in 5 years, and we're about 15 years into it, and it's been 50. And so, but then people walk away from that data and go, okay, so we spent $50 million on telehealth, and they think that's an incremental $50 million above and beyond what they would have spent. That's not the case, and Tim has had a great example. In fact, I've got both ends of the encounter where Mary at St. Clair had a child who I think was 8 or 9 years old, needed to see a dermatologist, and there aren't any pediatric dermatologists, save for our former Medicaid medical director, who's sitting in this meeting said, well, I'd do that. I'd sit on TV and see patients. And so as a U of L faculty, he started doing clinic, and he saw a child on TV that had been to primary care 8 times and had been to the emergency room 1 time over the course of, I think, of 16 or 18 months. And so every one of those doctor visits and emergency room visits rang up some dollars that were spent on that child's care. And it took, Tim, as I recall you guys saying, it took the doctor about 5 minutes to figure out it was flea bites because the child slept in bed.
That's right.
And so how much money was spent on that child's care, and how much trouble was that child put through and the family put through because the dog slept in bed with them? And we could have resolved that probably in one primary care visit if the primary care provider could have forwarded them to a dermatologist on TV. We could have cut the cost, cut a great deal of grief for the child and the family. So be sure when we look at expenditures for telehealth, we do not think of that necessarily as incremental savings, but I dare say every clinical encounter we do on TV probably cut some cost out of the system from unnecessary other provider visits. So, all right, so guys, thank you from the MCOs. I hope this is not the last time that we get together with you guys. That was very helpful. I hope meeting this group has been helpful for you. And guys, we're 12:22. I promise you, we're going to get you out early today, even. Rodney, I've got you next on the schedule, please.
We've had some really nice subjects today. Unfortunately, mine's going to kind of go in the other direction. Last Thursday, Donna and I had the very sad duty to have a conference or join in a conference call with our training center directors from St. Clair, Baptist Madison, UK, and U of L, to let them know that the cabinet was only going to be able to offer its New Year contract through the end of September, the coming fiscal year, after which that contract will not be offered. As you all have probably been reading and are aware, the enacted budget that we have for the Cabinet for Health and Family Services has been seriously reduced. We are struggling trying to figure out how we're going to make it through the year with limited general funds that we have, and it is tough times for us. Unfortunately, the training center dollars that supported these 4 training centers were 100% general fund, which made them even more difficult for us to continue. So while the cabinet did work very hard, and Donna worked very hard to try to save this, she really worked her brains out. We were unable to do so. So there will be a contract with the training centers. Those contracts are being completed now and delivered in the next probably few days or a week. But they will be through September 30th of 2014, and that will be the end of the contract. It does not mean that the cabinet does not fully support the telehealth board, its purpose. Donna will still be here and on board to provide administrative support, but and we have discussed from our perspective at least the impact of this. I would hope the board will continue that discussion and that we'll work together to try to figure out maybe ways to overcome this issue. And I can tell you that whatever plans that we can come up with, I will actively try to support those and see if we can try to continue whatever services that we can. But unfortunately, that's my bad news for today. So I'd be happy to take any comments, questions, or whatever.
September this year.
Yes.
So first quarter
of the fiscal year. No, still
after July.
Right.
How much funding we talk?
About 240,000.
Annually.
And if the training centers were curtailed or had to be disbanded, the practical implications to expansion of the network would be what?
And I've got some comments I'd like to, I will run through at some point. If we could, maybe any feedback from the group. We as training centers have a response, and then I think there's some others that may want to speak to this as well. Maybe this is the time to do it since you brought it up. Most of you guys know that the training centers were formed through the original legislation that was passed in 2000. The training centers are at UK, U of L, St. Clair, and Baptist Health in Madisonville. We oversee scheduling of the clinics, educational programming, administrative events, and we manage the statewide network itself. We also manage a online network schedule that runs everything. I do have great concerns about that. What it also does is it funds the 4 training centers to work collaboratively, not just with each other, but with other folks. I think we're all trying to figure out how this is going to play out for us, but I'm going to have to be really judicious with my time from now on. I mean, up until this point, if somebody calls me and says, hey, I need help, I'd like to do this, or I'd like to know what we can do with telehealth or how it can impact my organization. We as training centers will get together and come up with plans, and we'll make site visits, and we'll do all kinds of things. We're going to have to be really careful about doing that. So I don't know how much effort any of us are going to be able to put forward, and I'll leave this up to the rest of the guys to determine, and to speak to you guys on what the impact this will be on their organizations. But just to give you just a really quick snapshot, as we know people around the country that have statewide telehealth programs, I kind of break them up into 3 different types. You got the Wild Wild West, and these are states that no holds barred, do whatever you want, no real oversight at the state level. And there is a lot of creativity that's created in something like that. But again, as we showed the example earlier, if somebody on one side of the state wants to talk to somebody on the other side of the state, they may not be able to do it because they've created their own internal technologies. And then there's a network of networks, and that's very much what what the state has created with UK U of L and the 2 rural training centers. We allow people to do whatever they want, create their own networks, to build their own systems among themselves, but then we mandate a common platform where we can all talk to one another. There is some statewide oversight, but it allows people the creativity to create what they want. And then there are some states around the country where it is a wholly centralized, everything comes out of one place. In some cases, the communication lines come out of a central location, the technology is purchased for them. These are often on a subscription basis, so a community hospital or clinic partner would pay a pretty significant fee every month to be a part of this. But really since 2000, when the state legislation passed, we have been that network of networks. The impacts that this will have, there are going to be tremendous impacts, but I try to focus on some of the things that I don't think will continue to happen. Now, certainly, my providers, seeing their patients in circles around, we will continue to keep working that. I've just got to be, I and the other training center directors have to be really careful on how much will they work together to help others. What I'm getting to, we're probably going to become a whole lot more selfish going forward. And that may be a good thing. But I don't know if we'll see the same kind of collaboration between UK and U of L. I think we were one of the programs in the state where UK and U of L work well together. But without the, and also, you know, I don't know if the board of directors is going to continue or be able to continue. One of my concerns is that you have to be, you guys saw it today, you have to be approved by the board in order to be a member of the network to bill Medicaid. Now, if the board doesn't continue and doesn't have the kind of support that we have today, then we can't vote new people in. So those that can bill Medicaid, and new people would not be able to get onto the network. Again, we had talked a little bit about greater good activities. I think all the training centers spend a lot of time helping those that are probably out of their traditional catchment areas, and we'll have to be really judicious with the time. It will eliminate the online network schedule, which is, we pay about $4,500 a year to have that managed. I have some ideas on what we may be able to do with that. We can't function without that schedule because there are, you know, we have hundreds of users that look at that schedule every day and they know what is going to happen in the state because of that schedule. We have some really significant educational programming that I think could be significantly impacted. Madisonville, with University of Louisville School of Medicine, has had an ongoing rural training center program for 3rd and 4th year medical students. They spend the first 2 years in Louisville, they go to Madisonville for their last 2 years. And the concept and the purpose of that is to recruit kids from rural Kentucky to stay in rural Kentucky. And I think, as I understand, Steve, you guys have one of the most successful programs in the country in accomplishing that.
Yeah, we were ranked number 3 of the 35 rural programs that were looked at a couple years back. We were ranked number 3 in the nation in terms of the number of students we put in back into rural practice. And they receive all of their didactic lectures via the network back from Louisville.
And look, UK took a page from what U of L did, and we created the Rural Physician Leadership Program, which resides in St. Clair. Again, the medical students spend year 1 and 2 at UK, and they spend their entire 3rd and 4th year out there. We recruit kids from rural communities to stay in rural communities. And frankly, study after study shows that's the only way to really have an impact on keeping kids in keeping providers into rural communities. It also will eliminate, it also could impact the RNA program that comes out of Madisonville. And we have students in both Moorhead and U of L that their entire curriculum is connected for that. Steve, you guys connect at like 9 in the morning, and you're there most of the day.
Yeah, they're there their lectures go all day when they're doing lectures. It's the only CRNA program in the state. It's based here, and as Rob said, we have students in Moorhead, UK, and we've even had some out of Louisville that connected back to us for those lectures.
So, if you go around most states, the telehealth programs are fractured along competing organizational lines. And we have found a way to get past that in Kentucky. I am really proud of how everybody in the state works together. Again, talking about if the board happens to dissolve, again, we talked about not being able to add new members to the site. The governance that is provided through the statute, through the board, does offer some cohesion in this network, both technically, clinically, privacy and security, informed consent, and other areas of clinical practice. It will stop momentum. I mean, no matter what happens, it will certainly slow momentum. And I don't, you guys wouldn't be in the room today if telemedicine wasn't kind of a hot topic right now. It really is kind of rising on people's radar screen. And then I think those are the key things that will be certainly impacted. I don't want to downplay all the other things that are happening, but I think some of these things could continue to happen, maybe in a different format. The Commission for Children's Special Health Care Needs, I know we don't have somebody representing that group here, but UK and U of L work together to coordinate and really to push them along to develop neurology clinics with them, because what we found is between both of our programs, wait times for these kids with severe neurologic problems were pushing out to 3, 4, 5, 6 months. And we were able to push that timing down to where we're down to 4 to 6 weeks now in wait time. And, you know, as a parent, if you've got a child with that kind of profound neurologic problem, you don't want to be told 4 to 6 months. Again, Louisville's got the AIDS HIV clinic in the state prisons, and again, KTHN doesn't necessarily drive that. But I do know that U of L and the Kentucky Department of Pharmacy, Public Health is working on a pharmacy project to bring prescriptions to AIDS HIV patients who have kind of become out of compliance, and that would have an impact with KTHN. And we had talked about it with the prison system. We've got a psychiatric nurse practitioner in Western Kentucky that connects literally through my office and sees over 3,500 patients a year in the state prison system. UK has a state prison, Department of Juvenile Justice, psych consult service, sees a lot of patients. The state is working with us to develop a diabetes education series. This is not UK, this is not U of L, this is coming out of the Department of Public Health. But between us working together, we're going to pull this off, and it will have an impact on patients' care. We haven't even talked about Medicaid travel savings, and we've really challenged ourselves or been challenged to try to quantify that. That's a tough one, but that number keeps growing every year, and we know we can have an impact on that. And then, you know, one of the interesting things that came out of telehealth, we've told the story before, but St. Clair Regional Medical Center, because of telehealth, was able to recruit a child psychiatrist coming out of the UK child psychiatry program. And so, I mean, it was unheard of to have a child psychiatrist in a rural community. And then 4 or 5 years after they moved there, because of family issues, they had to move back to Lexington. But this guy still uses telemedicine to be a 100% FTE St. Clair child psychiatrist living in Lexington. And so they didn't lose that person because they moved. And again, without telehealth, that never would have happened. So there are, you know, we could go on all day long, but I think there are things that we do that support each one of our organizations, but I think we do a fair amount of work that supports the state as a whole. And so don't know where this is going to take us. I don't know what the impact's going to be, but that's kind of my discussion on the impact. I know David had some things he wanted to say.
Yeah, Ronnie, I'm not going to shoot the messenger.
Well, let me make a point. But I am the messenger, so I'm the guy you need to shoot.
Well, okay. As mayor of my small town, I know budget concerns. Fortunately, there's no one else who wants to run for the job, so I'm stuck with it. But I also know in my 45 years in healthcare, and being the person who did the first telehealth consult in the state, interestingly, it was a pediatric cardiology patient. She was the little cheerleader from Clearfield, Kentucky, and the first child psychiatry consultation where I learned not to leave a hyperactive 5-year-old in a room with $60,000 worth of equipment, and the first pre-op physical, a person from the Moorhead area who was going to go to Lexington for surgery. The out-of-pocket expense savings was rather significant. And I know through my work with Primary Plus for over 10 years, back when it was Lewis County Primary Care, our net savings on meetings alone was in excess of $150,000 a year, which in a struggling entity that at that time was seeing about 30% indigent patient population, that was significant. It will continue to be significant in the future. Those of us that contributed to this in the beginning saw a need, and I think there were a lot of folks, not just me, that
knew and understood that we had to build a standards-based approach. And I still believe that. And what I see in other states, there will be absolute chaos, not just the educational side at Trover and St. Clair, but there are students rotating all over the state who join back in for certain aspects of didactic via this system. That scheduling alone is rather phenomenal and tricky at times. So it's not just UK, U of L, St. Clair, and Trover. This affects Maysville, this affects Paducah, this affects every little wide spot in the road, virtually. It seems as though, and I understand Governor Beshear's managed $1.9 billion in cuts. I realize it's a hard decision. But the other thing is, as we look, and I know that the Cabinet's very interested in the manpower development process. This is one of the solutions. And if we terminate our ability to reach out into the community, the rationale for setting up these centers out there was so there was somebody joining on the spot. We call it a spoken hub process. But helping people develop processes in a standardized, systematic approach and giving them the tools to be successful. I would implore you to carry back the message that this probably needs to be reconsidered. Again, $250,000 would save. To me, this is equivalent to shutting down KHIE. I mean that seriously.
Other comments?
Thanks, Dan. Tim, Steve, Mary, I know you guys are directly impacted. I don't know if you've had time to kind of think through this at all or not.
I mean, we only found out Thursday, so none of our organizations moved that quickly as far as, what we're going to do there. So, it means if the funds aren't replaced from some source, I lay off an employee, and I do like you, I become much more careful in how I share my time, which my time is donated to telehealth. So.
In a feeble attempt to try to end on a somewhat positive note with this piece of discussion, because folks, I could tell you there's nobody more devastated in this room than Donna sitting there. I mean, she was in tears when this decision first came.
Well, I have an eye problem.
She has an eye problem. I think these were more than just her eye problem. So, I did call Rob and give him a heads up early, and Rob was very gracious, but obviously we're all very disappointed in this discussion. But this is my cabinet. It is my job to let you folks and training centers know this, and so I do that. But at an attempt to optimism, we have 90 days, and I would hope that this board decides that information about the impact of this, both to the present as well as the future for telemedicine in Kentucky, could be articulated in such a way that I can carry that back to the folks that have made this decision and see what we can do today. And I promise you all, I will do that. I can tell you that telemedicine is something that I think is absolutely essential to the future of the evolution of healthcare. I believe Dr. Langfield and other folks in this cabinet do that. But simply stated, and you all know this for each of your organizations, times are tough and every dollar is hard to come by. So, I'm hoping, Rob, that the board will get some impact data back to us so that we can take that message forward and see what kind of alternatives may lay in the future. Again, I don't want to raise hopes beyond what I should, but I also just don't want to lay down on this either, so frankly stated.
As a guest, I'm hesitant to speak out, but I will anyway. I'm sure this is a group that's more familiar with telehealth than most, obviously. and more than myself, I would say also, that I've had the opportunity to interact with UPMC's Center for Connected Care. I don't know how many of you have had a chance to either visit, go on the website, and learn. They had a very interesting model how they stood theirs up, but it was kind of a public-private partnership that has worked in a number of places, and it just so happened they were able to bring in some really big investors to help with that. One isn't so big anymore, BlackBerry, but at the time they were. If there things like that, and I know Dr. Watson, I don't know him personally, but I've met him professionally, and he's very passionate about this activity. He's the director, the chief medical officer, and medical director for that. And I know he has offered to speak to different groups on behalf of the initiative. He has a very personal message about why he became involved in it. It's very powerful. It has to do with something that happened to one of his patients, and there had to be a better way of doing things. And as a colorectal surgeon, he actually provides about 30% of his clinical interactions through telehealth, which is pretty impressive for a surgeon. So maybe some outreach to them to help with messaging to different constituent groups could be of some benefit, and I can help make some contact.
Well, at the risk of just being bold, which I always am, I think you guys have a vested interest in helping us try to overcome some of this stuff as well, frankly. Because the telemedicine network in the state is very vibrant compared to other states. If you're out of directions we pointed out, and these training theaters are a great deal of the reason why we've been able to do that. So, having said that, I'll be quiet now.
Well, the only other thing I would say, Rodney, is that there are challenges similar to this in multiple, times.
This is not the only crisis.
But the challenge and the opportunity is how do we create something that's truly sustainable? Because we can't, things aren't going to continue with grant funding or this little, pot of money here or there. How do we look at this together and say all stakeholders have to be engaged in this, and we have to create something that's sustainable and reinforcing, not just something that depends upon something else.
Well, we thought we had that with legislation.
Yeah.
Don't go there. I pass ordinances every month. I know what you can do with ordinances. Decisions have to be made. But again, that was the way to bring it into a position where it recognized the need for regulatory effect of an emerging industry that, quite frankly, is fraught with the ability to fraud, abuse. In the earlier discussion, I thought about the telephone thing. That's our new Florida, and God knows this state doesn't need to go through that again. So I think Rodney's thrown down the gauntlet here, and I for one, am willing to pick it up. And Steve's a little bit concerned about we talked early on about getting with technology groups, but and I'm talking back in the 90s and earlier this century, but being bound to a certain technology group was rather problematic, at least at that time. Maybe it's an opportunity now.
Well, and they, it wasn't just BlackBerry, and that was one example. They actually had several investors in their initiative that were from different industry that happened to be around that area, that they saw the value to the community and really saw it as kind of an economic engine to help improve the health of the workforce. And so they saw that, the large employers saw it as a value add to them to build the infrastructure in place.
You can set up a licensure fee for people in the system.
Right.
It's one thing.
Yeah. They did a number of things, including put about $1 billion worth of fiber optics around the city, but.
This is Tim Bickle, U of L, and one of the reasons the Connect MCOs were invited, the medical directors were to also today, something that we normally do when we invite guests to our board meetings is to say, and here we are, and we want you to use us. that was one of the things that with all the organizations is to let them know that with the new Affordable Care Act regulations are what you're empowered to provide now throughout the state through Connect is to give access to specialty care and education to these patients around the state where there is no specialty care providers and where education can be provided through the Kentucky Telehealth Network. Without a network, a collaborative working network like this, I'm reluctant to now say, okay, everybody, jump on board, call us whenever you want to, because like Rob said, we may be in business for ourselves. University of Louisville, I know, just approved the budget for my office. And when I first told the dean's office this was going to happen, they said, well, we're not exactly sure what's going to even happen with telehealth here. So that's the knee-jerk reaction. Hopefully they see the need. The University of Louisville is currently in the position to, they want to improve their regional outreach programs and rural outreach programs, but whether they'll do that in collaboration with any of the other facilities around the state, I don't know.
Mary, we haven't heard from you.
Yeah, I'm still crying. Sorry.
This for you guys that don't know, this hits a little close to home for Mary because her mother-in-law was seen for 8 years on TV with a memory disorder specialist. So she lived this. For any of you guys that have had a parent or a relative that lived with you at home going through this. So.
Exactly. And I really don't know. This is really going to affect our patient care and how our patients are going to be able to access those specialty services, because we may have to lose a staff person because very little of my time came out of the telehealth budget. The nurse that does our clinics, all of her time was in that budget. So, I don't know. We'll just see.
All right, Mary, thanks. Closing comments from the group. I promise I'm going to get you guys out on time. And I can't thank you guys enough. Having a group like this really is helpful for us.
I would make a motion, draft a letter to the Secretary. Telehealth Board would like to go on record that we think this is a wise decision, even in light of the budget crisis out involving law. And that I would request an extension for at least 1 year to give the organization and the community at large time to figure out a business approach to sustain this board beyond general fund funding. But 3 months is inadequate for any organization to look at their budget and to figure out how they can build a business plan. So whatever language you want to use, Rodney can't do that, and John can't do that, and I couldn't have done that when I was working here, but I can now.
Yeah.
So.
Well, Rodney did fought for us, and we did.
Well, I know. I have no idea.
We weren't going to get anything.
I don't doubt the support, but I can request it.
Okay.
And I would suggest that anybody who's sitting in here and elsewhere in the state would like to send a letter to the Secretary. Be fun. I have never called on this before, but
You're now a member of at large.
You can't fire me, okay?
You can't with old pay.
My salary could be double or triple, and it still can't.
The only thing, keep in mind that a lot of salary, my time, and others for support of the board is not being, that's going to continue, okay? It's just the dollars that fund the 4 training center contracts. So your language should be utilized in that fashion.
Yeah.
Or at least an explanation of why this may lead to the disbanding of the board.
No, absolutely.
Yeah, and then back to David's point, how are you going to ignore legislation if you don't have a network to implement the legislative intent, which is what he was trying to get done?
Sure. It wasn't intent.
It was done.
It's law.
Yeah, you know what to do.
Right,
You know.
okay. Yeah, and do we, I don't know, Donna, I don't know if you have everybody's email, but you guys took the time to come here today. You do?
I think I did.
Okay, if you weren't contacted directly by Donna, just throw a piece of paper up here that you guys sign before you get out of here. I just want to keep you up to speed on what we're doing. You guys were kind enough to come out here today, and so we're going to keep you in the loop. But any closing comments before we go today?
Russell seconded my administrator.
Oh, yeah, we're gonna do it. I don't need a vote for that. Again, what are they gonna do? Hold my pay?
Yeah, you do. You got a motion to second on the floor.
Okay, all right. We have a second. All in favor of drafting the letter to the secretary from the board, asking for a 1-year extension, please say aye.
Aye.
All opposed? All right, we'll do that. All right, guys, thanks. Next meeting is September 15th, so, unless we call a meeting prior. So, we don't need to move to adjourn, we're going to adjourn.
Can I mention something quickly? Since you mentioned that. The eHealth Summit, the annual Kentucky eHealth Summit, is on September 17th at the University of Louisville Shelby campus, and our team this year is around telehealth. Okay, so save that date, put that on your calendar, you're going to want to be there.
When is that?
September 17th. U of L Shelby campus.
Let's see, last year was at the Corvette Museum, we saw it. What's going to happen to Shelby campus? Donna, do you have an agenda for Mayfield? Yes. Where are they based? We got a whole pack up there. Thank you for coming, sir. Oh, good, thank you. Dr. Mark, see you all tomorrow.
If you try to bring something on the phone drive, it's okay. It's okay. Whatever that connection is, as long as you got that, we're good.
Okay. I'll bring
Good. Thank you. I've got a call. I'm not going to get you. Thank you. I appreciate
I was gonna say, when I saw the name, I was like, seriously? Right?
it.